Hi, I'm Alicia.
And I'm Robin, and you're listening to Bowel Moments,
the podcast sharing real talk about the realities of IBD. Served on the rocks. This week we talked to Kelly Issokson. Kelly is the Clinical Nutrition Coordinator at the F. Wijaya Foundation Inflammatory Bowel Diseases Institute at Cedars-Sinai in Los Angeles, California. She is the Course Director and Apprenticeship Director of the newly minted Cedars-Sinai Advanced Dietary IBD Education and Training Program, and her research focuses on the nutritional optimization of surgical patients with IBD. We talked to her about surgical optimization. We talked to her about this newly minted training program. We talked to her about the nutrition care pathway that she co-created with multiple other dietitians and providers through the Crohn's and Colitis Foundation, and we talked to her about her volunteer work and advocacy around nutrition therapy and access to medical foods. Cheers! Hi, everyone. Welcome to Bowel Moments. This is Alicia right now, and Robin will be joining us when she can. Unfortunately, in true IBD fashion, she got delayed at her doctor's office trying to schedule more tests. So you'll hear her jump in here as soon as possible, but I am so excited to start the show out right now with Kelly Issokson. Kelly, welcome to the show.
Thank you so much, Alicia. It's really nice to finally meet you and be on the program.
Awesome. For those of you who don't know, Kelly is a dietitian, and so we are definitely going to be hitting on a lot of topics that I know you guys are very interested in. So super excited to get you started. But we're going to start out with a very unacademic question of what are you drinking?
It's 10 a.m. So I am drinking Earl Grey tea. I love Earl Grey tea. It's so floral and it kind of smells like Fruit Loops, which was one of my favorite cereals as a kid. But it's warm and soothing, and that's what I'm drinking.
That's great. I love Earl Grey as well. Yeah, and I love the bergamot in it. You're right. It has a very floral note to it. So I'm a big fan as well. And you're right. It is midday for me, not morning. So I am drinking a latte. So, but hopefully someday we'll get a chance to drink mimosas together, and then that will make it a different sort of vibe instead. Yes. Next question for you, Kelly, is why did you choose IBD as your practice? Why gastroenterology?
So I kind of fell into IBD. When I was a nutrition student, I was really focused on enhancing my knowledge on nutrition care for diabetes. I have a lot of personal connections to diabetes, and I just felt like that was something that I needed to learn more about so I could help my family and community. But during my training in my early years, I was working with our pediatric dietitian at Cedars-Sinai. Her name's Erin Feldman, and she was pregnant. She was going on maternity leave, and she asked if I could kind of cover for her during her maternity leave at the IBD clinic at Cedars-Sinai. And this was about, 10 years ago. And I was like, yeah, sure. I don't really know much about IBD, but if you train me, I'd be happy to cover for you. And that was kind of my entrance into this world that I was very unfamiliar with. And not only was it a great learning experience for me, but it kind of also highlighted the lack of resources in this community. So when we look at communities with diabetes or heart disease, there's a lot of dietitians who kind of specialize in those, medical needs for the care of those patients. But with IBD, we don't see a lot of IBD focused dietitians. So after Erin Feldman came back from maternity leave, I went back to kind of general inpatient care, and I really missed working with people with IBD. And so over the next few years, I stayed in contact with our IBD center, and a few years later, they announced that they were opening a position for a dietitian in their adult clinic because they didn't have a dietitian and they wanted to bring somebody on. And I was super excited, and I signed up right away, and that was in 2013. And I've been working with the IBD team ever since. And it's just been so wonderful to watch our program grow and to kind of expand the access of resources to our patients with IBD.
We're really excited for that as well. I think the community can definitely tell you how excited they are for this to be better integrated into a lot of care centers. And friend of the show, Stacey Collins, has certainly talked about to us, and also I think on the show, about when she was in school to become a dietitian about how she did feel like the information about inflammatory bowel disease was lacking, that it did come from a lens of maybe more on the side of heart disease and diabetes care. And I know you're trying to change that. So that's exciting. One of the things you wrote down that you are very involved in, that you are the director, I think, of the newly minted Cedars-Sinai Advanced Dietary IBD Education and Training Program. How did that get started? What's the intention for this? Tell us your big vision for this program.
Well, over the years, we've focused research on nutrition and its impact on our patients with IBD and their outcomes. And one of the things that we recognize is, the lack of nutrition-focused providers that can help people with IBD. And so with a collaboration with the Helmsley Foundation, they have provided us with a very generous grant to start a training program for not only dietitians to enhance their nutrition-related knowledge for IBD care, but also providers, so physicians, nurse practitioners, physician assistants. So we are very excited to be launching this new program. We're launching it in a two-pronged approach. So one aspect of it, the part we're kind of focusing on right now, is the dietitian apprenticeship. So we are currently seeking a dietitian to come and join us in Los Angeles at our IBD Institute and spend 6 months with us, with our team, learning all about the intricacies of IBD care for our patients. So the hope and the goal is that they can gain all this knowledge and then go back to their home institution and start their own program, grow their own program. So essentially bringing these specialties to underserved areas so that patients ultimately have better access to nutrition care.
So is it like a train the trainer type program?
Exactly. Yeah. So we're really excited about it. And I know this is definitely a much needed area that needs to be addressed. And so I'm really happy that we're finally doing it and kind of bridging this gap.
That's very cool. And I think that's really such an exciting thing for you guys to start. Robin has joined us. Hello, Robin.
Hello.
Hi, Robin.
Kelly. Hi, Alicia.
Well, welcome to the show, Robin. Yay. Robin, what are you drinking?
I am drinking a fancy coffee from Starbucks, not sponsored by. I have a Venti hot mocha with an extra shot. People who are naysayers for coffee, don't come at me.
Maybe we talk about that, Kelly. Why do people with IBD, why shouldn't they drink coffee? No, next time in another show. Kelly, one of the things that certainly has come up on the show a lot is that I've joked that we've become the J-pouch show at this point, because we have had a lot of folks who have gone through J-pouch surgery or have had surgery for their inflammatory bowel disease. And this is one area that you're particularly interested in, is how do you do nutritional optimization for surgery for folks with IBD? So talk to us about, how did you land on this? And then what can you tell us that you have learned in this area?
Well, unfortunately, with IBD, a lot of our patients can experience malnutrition. And with the advances in medical treatments and medications that are available, there has been a decrease in surgery rates for patients, but still surgery remains a very effective treatment option for patients. So when we look at the traditional surgery model, the research studies around surgery in people show that when patients are optimized with nutrition before surgery, they tend to have better outcomes. So they have shorter hospital lengths of stay, they have less infections, and they get to go home and get back to their lives quicker than in patients who aren't nutritionally optimized. In these studies, IBD patients have traditionally been excluded. So there isn't a lot of research or studies around people with IBD who are going into surgery and how nutrition affects outcomes. What we're learning is that when we apply these same principles, and it makes sense, to optimize our patients pre-op, that they do tend to have better post-op outcomes. So that's what we're kind of focusing on at Cedars-Sinai, is how do we best optimize our patients before surgery? And then how does this affect their outcomes? Does it does it lead to the same decreases in hospital length of stay and complication rates? So in our patients that are going through the program, I see and I get lots of positive feedback that, they have a good experience. But I think it's great that we're kind of focusing in this area because, again, a lot of patients don't have access to providers, or they kind of don't even really consider the nutrition state before surgery. It's kind of like an afterthought. So I'm really happy that we're focusing on this.
So I'm going to give you a hypothetical on this one. So you have a patient, ulcerative colitis patient, looks like J-pouch is the next step for them. They meet with you, they have a surgery coming up. It's a little ways down the line. What do you do? What's the first thing you do with them? How do you start preparing them to be in the best place they possibly can nutritionally for that surgery?
I think in general, what providers can do or patients can ask is, how is my nutrition status? So just screening the patient, as soon as they know that surgery is part of the treatment plan, just getting a better understanding of how are you eating? How do you feel? Do you feel weak? Have you lost any weight without trying? Those simple questions can really give a lot of insight into how that patient's doing nutritionally and metabolically. In our program, we have all of our patients preoperatively meet with a registered dietitian and a nurse practitioner to talk about medication changes that need to happen. We ideally want to get them to be on the least amount of steroids possible because that's associated with better outcomes as well. How does medication change during surgery or after surgery? Would they continue biologics? When do they resume? And then we talk about, dietary needs. How does the diet change? What do we need to do before surgery? We need to make sure you're getting plenty of calories and protein. There are specific surgical drinks that are enhanced with certain nutrients to promote healing and recovery. And so we encourage patients to consume those at certain intervals before surgery. So we touch points with the patient at multiple times throughout their surgical journey, both before surgery, immediately after surgery. I see them in the hospital during their recovery, and then a few weeks after surgery. It's a 10-week program. I think it's nice because the patient always kind of has access to me, and they can reach out to me if at any point during their journey they have questions or they're confused about what to eat or they're struggling. A lot of times preoperatively, patients can really struggle with just being able to nourish. And so helping them to understand, how can we modify the diet so that, we can better control your symptoms and make sure you're getting those nutrients that you need that are so optimal to, your healing and recovery. So I think it's a really great program. But again, in these other centers or other institutions where maybe there isn't an IBD focused dietitian or they don't have a prehab program, which is a very novel idea, just starting with nutrition screening is a really simple, easy place to start. And then if you realize, hey, this patient, isn't eating or they've lost a lot of weight, referring to a dietitian can really make an impact on that patient's treatment journey.
Would you say the same is true for someone in a larger body that may also be presenting as malnourished? I just feel like in the IBD space, a lot of people tend to lose weight, when they're in flares and in that situation, but it is not true for everyone. And so is there a different approach or changes that would be made for someone who their body reacts in a different way when they're in a flare and having to go through surgery?
So that's a great question. There's a lot of weight stigma in our community and in the medical community and in IBD. And what we're learning is that, one of the ways we classify quote obesity is by using the body mass index, BMI. And unfortunately, BMI is a very poor prognostic indicator of health. So just because you have a BMI of 30, you would be technically classified as obese. That doesn't make you unhealthy or unfit for surgery. One thing we're learning in studies is that body composition is really important and predictive of outcomes, of whether or not you will need an emergent surgery and how your recovery will be after that surgery. And when we see patients, even patients with a lower BMI with low muscle mass, that's an important indicator of how they're going to, respond to therapy, how their outcomes are going to end up. So in patients in larger bodies, we want to look at their body composition, and we can measure that in a couple of ways. One is called a hand grip strength, and I use that in clinic And it's basically this tool that the patient squeezes a few times, and we take an average measure, and then we compare that to a norm for their age and gender and, depending on which hand they're using. And then the other way is by using imaging studies. I will look at a CT scan if they have one available. I don't request one specifically for this, but it does provide really useful information for me in terms of assessing how, their muscle mass is. Do they have adequate muscle area, or is it kind of decreased? And if so, we really want to focus on making sure that patient's getting the right nutrients before surgery, enough protein, enough calories, so that they don't, further lose their strength and take longer to recover. I don't tend to recommend weight loss just because a patient's of a certain BMI. I think that's not good care. We want to, see what the health status of the individual is, regardless, of their weight. Weight is one thing that we look at, but it's not the only indicator of health. And that's really important to recognize and to consider. Now, I will say that surgeons will sometimes refer patients to me for weight loss because it is easier to perform certain surgeries if there's less mass in the abdominal area, if there's less fat mass. And so that can be a challenge as well, because if the patient to me doesn't seem like they need to lose weight, the surgeon is saying this is going to make their surgery better. That's one of the things that we kind of struggle with, is kind of like understanding how to handle that situation.
Yeah, that seems like that would be really challenging to ensure that you're optimizing their nutrition and they're not malnourished while also helping them lose weight. Seems like a contradictory process somewhat.
Right. Exactly. We don't want to induce malnutrition, right? The ultimate goal shouldn't be weight loss. It should be metabolically optimizing that patient for the best surgical outcomes.
Wow, that's a tough one. So I'm curious, you're right. Not everybody has access to a center that understands IBD, like pre-surgery, all these things. Not a lot of places that have dietitians that are trained in specifically inflammatory bowel disease. Are there types of tests that you request for your patients that are not something that you think is normal, quote unquote, for other dietitians based on their training that may not be IBD specific, that you think patients would need to ask for specifically if they wanted to get a fuller picture of how they're looking nutritionally with their inflammatory bowel disease?
Yeah, so specifically for surgery, there are labs that we check before they have their operation. We want to make sure patients aren't anemic because that can be really important for wound healing. We check zinc levels because that's also important for wound healing. Vitamin D, some studies show that that can predict surgical outcomes. So we just like to kind of, check where that is and optimize it if needed. And then B6, vitamin B6 or pyridoxine, that's commonly low in our patients. And so we like to kind of screen for that and make sure that that level is normal. In addition to, I just want to jump back to the anemia. In addition to that, we check iron panel. So patients can be anemic for chronic disease related causes, or their anemia can be due to iron deficiency, B12 deficiency, folate deficiency, B6 deficiency. So there's lots of kind of micronutrients that can lead to that anemia. So we want to narrow down and make sure that, that anemia isn't nutritionally related. And if it is, then we correct that. And then for other patients, we recommend routine nutrition labs based on their initial nutrition screening. So I've done some research with the Crohn's and Colitis Foundation. A few years ago, we published a paper on the nutrition care pathway, which is a suggested care pathway for patients with IBD. And there's steps within the care pathway that are recommended for the provider to do to ensure that the patient is kind of, optimized nutritionally. So it starts with screening. We recommend using the MUST screening tool or the Malnutrition Universal Screening Tool. And then depending on, if they're high or low risk for malnutrition, then there are recommendations based on which labs you should check and at which intervals and, when you should refer to a dietitian. So that's a really great reference for providers and patients who maybe haven't had a conversation with their provider about nutrition or want to know more about their nutrition status, that's a really good one to kind of reference and bring to the office and say, hey, we haven't checked these things. Is this important for us to check? Does this apply to me? Because we all know, right? We all know that nutrition and diet, these are number one priorities for patients. They have these questions. Sometimes they feel comfortable to talk to their providers about them. Most of the time, they're going to the internet or social media or friends for advice, for guidance. That's not always evidence-based. Sometimes it can be harmful. And so it's really important to, if you have these questions, to bring it up to your provider, because then they know that this is a priority for you. This is your visits with your providers should always involve shared decision making. And sometimes patients, it's really important that you advocate for yourself, especially if something's at the top of your list. If you're really concerned about it, you should definitely bring it up and start that discussion. Another study that we did with the foundation a few years ago was looking at providers and their nutrition related knowledge. And we know that providers, especially dietitians, deem nutrition as very important in the management of IBD, but they don't feel confident in providing that education to patients or that guidance, or how, where do we even start with, optimizing this patient? So that's another thing that we really hope to address with this advanced dietary IBD education and training program. The other arm that I didn't mention earlier is an executive program, and that's going to really focus on enhancing the nutrition and diet related knowledge for physicians, nurse practitioners, physician assistants, and also dietitians, so they can, have these conversations with patients comfortably.
Yeah, I think the study I found on that, and you can tell me if this is not what you're referring to, but that it was less than half of all providers felt they had access to adequate nutritional care resources to help initiate and guide a discussion, was what was in the article. And that was shocking to me, but also not shocking at the same time, because I do feel like, and we've talked about this on the show, of that there's so much at play when you're talking about inflammatory bowel disease. There's the diet, there's the disease, there's the mental health, there's all of these things, there's pelvic floor, health, and all of these things wrapped up, that it's hard for the provider to feel like they know absolutely everything. And so I feel like at times some providers are maybe reticent to open the door to something that they don't feel like they really have enough knowledge to be able to address, because once the door is open, you can't close it, because now you've put it out there. And so I do worry that sometimes that's the barrier to starting these conversations.
Oh, absolutely. I mean, you bring up a very important point. And I've heard that from providers too. When I come to medical conferences, when I talk to physicians at other centers, yeah, we know, they say, yeah, we know diet's important, but we don't have a dietitian that we work with. So if we start that conversation, then what are we going to do? How are we going to help that person? So I'm really hoping that this training program helps to not only provide more dietitians and physicians who are comfortable having these conversations, but really closes that gap and reaches these patients in these underserved areas, in these areas where, there isn't an IBD institute and there isn't somebody like me who's been there for almost 10 years to help the patients. We need to be able to, provide people with the resources they need to help patients with these really important questions.
I do think developing a training program specific to dietitians so that they do understand the needs of the IBD community, or the needs of the GI community, even at a larger level, versus the needs of a diabetes and heart disease sort of community, because they are different, and this. But if you're spending the vast majority of your time in this area with one group of people and not the IBD community, yeah, we have a lot of people that then have to do a lot of additional training beyond their master's degree, and to feel like they're really the best source of support.
I'm seeing a big shift. During my career, I've seen a shift in the resources that have been available for providers. When I was a young dietitian, what was available to me for IBD education is low fiber. You give them a low fiber diet handout. And I work with the Academy of Nutrition and Dietetics. There's a subspecialty group called Medical Nutrition Therapy Dietitians, specifically dietitians who focus in GI diseases and disorders. And they've done great work in creating educational content for dietitians to give to patients, so that it's not just a standard low fiber diet education. I mean, that is such a disservice for our patients. And not only that, it can lead to long-term dietary restriction, decreases in food-related quality of life, which is super, super important for our patients and so often overlooked. And it's terrible advice. It's not good care. So I'm really glad that this is being addressed on multiple levels. And I think it's great for our patients because they do not have to follow low-fiber diet. That is not an IBD diet. Now, there are, modifications that we can make to help control symptoms. And, my personal feeling on that is that, when we modify the texture of the diet, a lot of times patients are able to tolerate that food better, or if we change the portion size. So, for example, if you're flaring, first of all, a kale salad is probably not going to be appealing to you. It's got a lot of insoluble fiber that is going to, increase output. But maybe a little bit of cooked kale mixed in a pasta sauce and ladled over some noodles, that's one way that we can, fortify that meal and give you the antioxidants and, vitamin C and, all the micronutrients that are so important for healing when you're in that very sensitive period. So yeah, it's way more nuanced of a conversation that needs to happen with patients. So I'm really happy that we're finally getting there and addressing it.
I think it's great you're thinking in that way, though, because you're right. When people are not feeling well, they're like, I'm going to eat my rice, my mashed potatoes. And but what are some ways that you can add some additional nutrients into what's already appealing at that point, but in a very safe, non-scary way? I think that's been the thing, and Robin, you definitely can chime in here, but that's been the thing that as we're talking to more and more people living with this disease and being part of this community, is that food gets really scary for folks and becomes, a real source of anxiety and fear. And like you said, quality of life really changes. So talk to me about how you address that, because there's not only a dietary factor there, there's a psychological factor there. So as a dietitian, you then become counselor and dietitian.
Yes, I will add, and I'm not looking for personalized nutrition therapy here, but just for context, Alicia knows this about me. When I was in the worst of my most recent flare before surgery, I think I ate rice, like bland chicken with lemon or lime juice for a year and a half, maybe 2 years. I think I was able to add avocado in there. And for some strange reason, black beans didn't bother me, but I lived on those and bananas. I lived on those few ingredients for well over a year.
Yeah. And so this is why patients need access to a dietitian, because that's just not acceptable to go that long on that restricted of a diet. It makes sense to fear foods when you have symptoms, when your guts are inflamed and you're not absorbing your food and it's going through you quicker. Seems like every time you eat, it just comes right out. It makes sense to view food as the enemy, as a really negative thing in your life. And the problem is that we have to eat to survive, and we have to eat multiple times to survive. And so just kind of confronting that multiple times throughout the day can be very traumatic for a lot of people. I think when it comes to a point where eating is so challenging that you'd rather skip meals, or, you're only eating a few foods and you're not able to advance beyond that. It's important to involve a GI focused psychologist, because like you said, it impacts your, mental health, your psychological state. And so it's really important to kind of approach it in a multidisciplinary fashion. But I work a lot with my patients on food reintroduction and developing safe lists, because if you Google what to eat for IBD, you're going to find a million foods, more foods to avoid than foods that you should be consuming. So it really plants a seed in people's heads that, food is not something that, I can enjoy anymore. It's not good for me. It's just going to make me feel miserable. So how can we turn that around, flip that script, and find out, what is working for you? Diet is so personalized. It also changes with your disease activity. It also changes when we optimize medical therapies and we get you on the right treatment. So if we can get that inflammation to subside, then we can start to expand the diet out. And even when you're symptomatic, there are things that we can do to help expand the diet. So, people usually rely more on bland foods because those tend to be tolerated a little better. And then we're also learning from studies that fiber is really important for symptom control. And even when people increase fiber, they tend to feel better. That's not talked enough about. Even people who are flaring, who increase fiber in their diet, tend to have symptom improvement. So how do we do that, right? And so we utilize a lot of like slow reintroductions in my practice. We start with foods that are least triggering, least anxiety provoking for patients, foods that they want to try, foods that they love, that they haven't had in months or years. I had a patient come to me once with a Post-it note of like 8 foods that she had been eating for years on her low fiber diet. She was feeling great. She's in clinical remission. She's been in remission for years. She had no idea what she was supposed to eat because 10 years ago, when she was admitted to the hospital for a flare, she was told she needed to follow a low fiber diet. And so these are the foods that she was told were safe, and that's what she's been doing. So yeah, building up that list is important. I ask my patients, write down a list of foods that you want to introduce. Let's work on one food over 3 days. Start with a small portion and gradually increase it based on how your body responds, how you tolerate that food. And it's just so, this is why I do this work, because it's really delightful for me to assist a patient through that process, to have them, learn that food is not the enemy. Yeah, it's really important work that needs to be done.
Well, and so much of people's social life is tied to food, and, you go out to eat with your friends, family sort of celebrations tend to revolve around food. And so when you are missing that, there's an entire component of your life that feels like it's inaccessible in addition to not loving food anymore. And I love food, so I can't imagine like how hard this must be to go from a place of like, this is where I get a lot of joy and solace and connection, to not having that. That's a huge lifestyle change for folks. So that's hard.
Right. And that's one of the things, when I'm in the multidisciplinary clinic at Cedars, one day we were seeing a patient, and I work with Dr. Steph Targan, and went back to Dr. Targan and I said, this patient's really struggling to eat because they experience a lot of urgency and diarrhea. And, this is really troublesome for them when they go to work. So they're just skipping eating during the day, and they only eat at night once a day, and they've lost a lot of weight. And then he says, that's really important information to know, because that means we need to adjust their medical therapy. So I think Stacy's mentioned this in the past too. I love Stacy. And, I don't work in a silo. I work with a team. Your treatment isn't just about diet. Diet is part of the treatment plan, but it's not the only part. And, it's an important aspect of care. And I love that our providers at Cedars, appreciate that. It's not ignored. It's not overlooked. It's important information for them to know, and it directs care.
I think that is so important. We literally just talked about this in my job. We were talking about basically putting together kind of a checklist of how can you be working with your patients around what they need to bring to the attention of their medical team, because there are times where, you get into your doctor's office and you just kind of, how are you feeling? Fine. And you forget all of these things that maybe have gone on. And how do we make sure we put some things together? Like, even as you're sitting in an infusion chair, your infusion nurse can be somebody who can help get information to your doctor around like pain and other symptoms that are happening that you may not think are, things you really need to be looking at, but are really vital information around whether your treatment is working or whether it's not working, whether what's happening is working or not working.
Right. And asking that question, how are you eating, is a great way to start that conversation.
What are you eating?
If providers just ask that, exactly, what are you eating? I'll go into a room and patient will say, oh, I'm just eating a regular diet. Okay, what does that mean? Oh, I have rice and, chicken and tofu and applesauce and, and it's fine. And, they have stricturing disease, and they're clearly not having, nuts, seeds, popcorn, fiber. They're self-managing so that they don't experience obstructive episodes, or, they don't run into issues. So yeah, that's super important for every provider to ask.
I feel like it's similar to whenever they say, so how much pain are you in? And someone says only the normal amount of pain, right? The same thing with food. It's like the normal amount of pain is 0, you would think, but that's not always the case. And so when you ask, what are you eating? And they think a normal diet, and it's like me eating rice and chicken and avocado with lemon or lime to spice it up, So I don't know. I feel like if you're a patient and you're listening and you need permission to talk to your doctor about your diet, I I'm giving it to you right now. You have permission to ask all the questions, to find out if what you're eating is right, to ask for labs, all of the labs that Kelly mentioned on here and that Stacy has mentioned previously. Like, here's your permission slip.
I think that's great advice. Another doctor that I work with, Dr. V, Dr. Vasilauskas, but commonly known as Dr. V, he's wonderful, really, really encourages, healthy lifestyle in his patients and focuses on the importance of nutrition as part of patients' care. He asks that patients start the visit by, what are your goals for today? What do you want to get out of this visit? Because they could be, like, the patient's goals can be wildly different from what the provider's goals are. And the same with me, when I see patients on my schedule, I think, okay, this patient has IBD, they have structuring disease, this is what I need to focus on for, education, these are the labs I need to check based on the disease location and activity. And then the patient comes in and they're like, my birthday's coming up and I want to eat my favorite recipe. How can we do that? Like, that's their priority, that's their goal. And that's so important to, address that goal during that visit, because that patient, that person might only see me once, and you only have how many minutes with your provider, right? Your physician. So writing down those goals before the visit is really, really beneficial.
For sure. And Robin, it reminds me of, I think this has come up on the show, when like you have the pain scale of like the frowny, sad, crying face all the way up to like the smiley face of like, that can mean vastly different things to people. It's almost like that's the same thing when you're measuring every aspect of your inflammatory bowel disease. Are you in the sad, crying face phase of your diet, or are you in the happy face phase of your diet, and
Right.
or somewhere in the middle? And I do think, one of the things I hear in this conversation, the same thing is like, if you have a list of 8 foods that are what you're eating on a regular basis, there's hope that you can expand that list beyond those 8 things in working with people that really understand your disease, your doctor, your dietitian, your psychologist, to help you expand that. So that feels hopeful to me. And I like that. So I want to say that I feel hopeful in that area because it's so important.
Mm-hmm.
One of the other things that you are actively involved in is doing some advocacy work around access to nutritional therapies, nutrition, like medical foods in particular. So talk to us a little bit about that. How did you get involved in that? And then what are you doing to expand access to these things?
So patients typically have better access to resources that are reimbursable, right? So like a person, if they have diabetes or kidney disease, these 2 conditions are covered for dietetic services. You could meet with a registered dietitian and get counseling on how to modify your diet to improve your health outcomes. Unfortunately, those are the only 2 conditions that are covered for medical nutrition therapy. So if you have IBD and you want to see a registered dietitian, a lot of times that cost is for you to bear. It's out of pocket. It's not covered by your insurance. Some private payers will cover the service, but most people will have to pay out of pocket to speak to a dietitian. And this shouldn't be the case because, as we've talked about, nutrition is so important in the care of people with IBD, and it does affect outcomes. We see people have better outcomes when they're well nourished and when they're getting adequate calcium and vitamin D and iron. They have better bone health. When they're getting enough protein and calories for surgery, they, recover quicker. So patients should be able to access a registered dietitian too, but they can't at the current time. And so the Medical Nutrition Therapy Act is one that we can really push for expanding services of dietitians to not only people with IBD, but with other chronic conditions, right? Celiac disease, where the only treatment is a gluten-free diet. Patients do not have that, service covered to see a dietitian for nutrition counseling for the only therapy that helps their disease. So it's just mind-boggling that patients don't have access to a dietitian. And these are some of the research priorities of, the societies that I work with, the foundation, Crohn's and Colitis Foundation. It's an advocacy priority, the AGA, A&D. It's really important that we advocate for this expanded coverage. The other one is the Medical Nutrition Equity Act, and that expands coverage for medical foods for people who need them. So one of the most well-studied and effective diet therapies for IBD, specifically for people with Crohn's disease, is exclusive enteral nutrition. And that's where you replace all of your food with a formula, and you only drink a formula that's nutritionally balanced and provides you with enough calories and protein and micronutrients for you you to heal. You only drink that for a period of 8 to 12 weeks, but that can induce remission in Crohn's disease, right? And it can heal the mucosa. We're not sure, why this magical formula works in that way, but it works like steroids. It's a good alternate to steroid therapy for people who are able to tolerate it. And so if one of my patients wants to start exclusive enteral nutrition, they're maybe experiencing a Crohn's flare, they have to pay out of pocket for that. And it's just unacceptable. It is a, well-established medical treatment for inducing remission, and it should be covered by insurance. But that's the whole point of the Medical Nutrition Equity Act, is to expand coverage for medical foods for those reasons. Yeah.
Well, and it's my understanding that you can get TPN covered if it's delivered via tube feeding, but if you have to actually drink it, then it's not covered. Am I understanding this correctly?
TPN stands for total parenteral nutrition. So that's where we insert nutrition by the vein,
Okay.
IV nutrition. But you bring up a good point. So if a patient gets tube feeding for their exclusive enteral nutrition, so if a tube is inserted and it's deemed medically necessary and permanent, meaning they need it for a certain period of time, 90 days or more, then it will be covered by insurance. But, a lot of my patients drink the formula by mouth. They don't want to insert a tube. And,
Right.
it just doesn't make sense that it would be covered by a tube, but not, if the patient drinks it orally. So that is kind of one of the nuances of prescribing for some providers. A lot of times our peds patients will self-insert the NG tube at night to administer the formula that way. And yeah, it is usually covered more often by insurance.
But nobody wants a tube if they don't have to have it. I mean, if they can drink it by mouth, I don't know that anybody's going to be like, sure, sign me up to do an NG tube. Yeah. And there's stigma associated with it if you have to use it during the day as well. Like there's stigma with having a tube coming out of your nose, so I feel like there's just a lot at stake there.
Can we ask you about your challenge that you do every year?
Yeah, every year on World IBD Day, May 19th, which is one day after my birthday, we do an EEN challenge where, we highlight on social media what exclusive enteral nutrition, EEN, what it is, how it works, who would be appropriate for it. And then we talk about the different kinds of formulas. So I challenge providers to just live one day on EEN, try Ensure, try Boost, try Modulin, try Kate Farb, try all these formulas that are available for your patients. That way, you know what they taste like, you know how to get them, you know how much they cost, so that when you have that conversation with that patient who's maybe like, I want to do exclusive enteral nutrition, then you can say, well, let's talk about that. Yeah, well, I work with this dietitian and they can help you get started, but just let you know upfront, it's not usually covered by insurance. These formulas can typically be expensive. Is that within your budget? You can have these conversations with your patients and be more informed and provide them with better information, if you live the day. So yeah, World IBD Day, May 19th, EEN Challenge. I hope you'll join us.
That's awesome. I love that. I think that's such a great way to raise some awareness amongst the providers. And then maybe you also have some recommendations for what tastes a little bit better as well, if that can be in your budget, because I'm guessing there's a big difference between them.
Oh yeah. I mean, I personally like Ensure. I just love that creamy, sweet taste. But some of my patients are like, I need a less sweet formula, Kelly. Like I cannot, or they want organic, or they want latte flavored. And so different brands provide different, benefits. They're all effective for inducing remission. So that's the good thing, the patient can decide which one they prefer.
Do you have to stick with the same formula? Like if you start with Ensure, stay with Ensure?
We recommend that just because that's what we studied, right? We haven't really studied people kind of switching. And one of the reasons we feel like it's effective is that it is kind of emitting some sort of dietary antigen and you're getting the nutrients you need. So I'm not sure. We recommend people stick with the same brand. Just, if you're going to do it for 8 weeks, we don't want to kind of increase the odds that it might not work. So
that's very fair. Well, Kelly, it has been so much fun to talk to you, but we are running out of time. So final question for you, and we already talked about this, I queued you up on this one, is if you had one piece of advice for the IBD community, what would it be? But in your case, I want yours to be, because you've done research on other providers and dietary, advice to them or dietary factors. If you can angle it that direction, I'd appreciate it.
Yeah, so my advice is to familiarize yourself with the benefits of diet and nutrition therapy in IBD care. Familiarize yourself with the different diets that have been studied and when we would apply them and what that means for patients, how to do it. Connect with a dietitian in your local community so that, while you're brushing up on your own knowledge and even after, you have a resource for your patients. As I mentioned, I didn't always exist at the adult IBD center at Cedars-Sinai. It was the providers who reached out and said, we want a dietitian. This is important for our patients, and we recognize that, and we can't answer these questions. We got a million other things to do for our patients, so can you help us? And encourage that person, support that person, take them to medical conferences, help them, grow in their education so that they can be a great resource to your patients as well. Dietitians, they are amazing in what they can do for patients. We sit with people, we listen to them, we help them understand how to navigate eating and how to improve their quality of life. So that would be my number one recommendation to providers. And of course, join our executive program to learn more.
Awesome. Any advice for patients?
Ask your provider if you have questions. Like Robin said, if something's a priority to you, write it down. It's your goal. This is your life. You are paying this provider to care for you. And if you have a question about how can we optimize my nutrition? Do we need to be checking labs? Do I need to be on a specific diet? Can I eat the strawberry without peeling it? Ask those questions. It is a life changer. And definitely you have to advocate for yourself because, as Alicia mentioned, providers don't feel comfortable talking about these topics. And so just bringing it up is really important because then they understand what your priorities are, what's important to you, and how they can better help you.
That is awesome advice. Thank you so much, Kelly. We really enjoyed our conversation, and I know that our listeners will learn a lot. So we're going to wrap up by saying thank you to Kelly and thank you to everyone who's listening, and cheers.
Cheers.
Cheers. Hi, this is Kelly, and if you enjoyed this episode, please rate, review, and share with a friend.